Coming up in this episode. So, what you get is when you move the head quickly to the side, the eyes initially move in the direction that the head is moving in, and then they realize, oops, we were meant to not do that. And so then you have this corrective saccade back to the examiner's eyes. So basically, the eyes move with the head for a split second, there's this delay, and then there's this corrective saccade back into the middle. If you blink, you might miss it. So you have to look really, really, really closely for the corrective saccade. Hello, and welcome to the next installment of Risfeld Neurology Education, a not for profit, free open access project with a philosophical touch exploring all areas of clinical neurology, meant for medical students through to neurologists and all health professionals caring for patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. I'm really excited to present this episode because it's our first episode in the neuro-otology and vertigo series, and it's also in the clinical methods series, and it's titled Central Vertigo, HiNTs Plus, and Dix-Hallpike and Related Examinations Theory with Associated Pearls and Pitfalls. Before we dive into it, a legal disclaimer. The content of this episode is for educational purposes only. So let's dive into it. What does HINTs Plus stand for? It stands for Head Impulse, Nystagmus, Test of Skew, Plus, the plus referring to hearing. When do you use a HINTs Plus examination? Well, it's designed for use in a patient with an acute vestibular syndrome. So that means a sudden onset, persistent vertigo or disequilibrium. This is opposed to a patient who has presyncope or lightheadedness as a cause for their quote unquote dizziness, which isn't actually truly a vertigo or a disequilibrium. However, there have been some studies which have taught us not to overinterpret the description that a patient provides in regards to what they mean by dizziness. So that's a word of caution. Just because someone uses the word lightheaded or presyncope, if there are other features on the history or the examination that are supportive of this actually being more of a vertiginous, disequilibrium, neurological flavor to their presentation, don't discount those causes and those differential diagnoses completely just based on the way that the patient chooses to describe the word dizziness, which is notoriously difficult to describe. It's also not really designed for use in a patient with episodic vertigo. And of course, episodic vertigo can in turn be triggered, such as in the case of BPPV, benign positional paroxysmal vertigo, or it can be non triggered, for example, in the case of Meniere's disease. However, one point I will make here is that if it's the index case of Meniere's disease, then by definition, you may not know that it's episodic, because how could you possibly know if it's the first time that it's come on and the patient still has the syndrome? Then you can't know that it's episodic as opposed to not episodic. So it would be reasonable to work the patient up as if they were an acute vestibular syndrome in that context. What is the HINTs supposed to actually achieve? It's supposed to be able to distinguish central causes of vertigo manifesting with an acute vestibular syndrome, and in particular, when thinking of a posterior circulation stroke, from a peripheral cause. And in particular, we're thinking of vestibular neuritis. And annoyingly, I was always taught to say vestibular neuronitis, and I've got that drilled in my mind. But I've noticed that in recent years, everyone starts saying vestibular neuritis. So I've had to retrain my mind and my mouth to say vestibular neuritis, not neuronitis. Of course, the HINTs exam should be performed in conjunction with a NICE exam, so a National Institutes of Health Stroke Score, or NIHSS, in the hyperacute stroke setting. And that's important because we're thinking about posterior circulation stroke in the context of an acute vestibular syndrome. So if someone's had a brainstem stroke causing vertigo, it's a bit of a dead giveaway if the patient also has a hemiparesis, isn't it? So if you've knocked off, in addition to some of the brainstem nuclei or some of the corticobulbar fibers involved in the vestibular system, if in addition to that you've knocked off some of the corticospinal tracts and you've caused a hemiparesis, then it's pretty clear that the patient doesn't have vestibular neuritis. So really, a HiNTs exam should be done in conjunction with a full neurologic examination, or in the hyperacute stroke setting, in conjunction with a NEIS instead. There are some other things that are good to know to help contextualize your HiNTs examination. So it's good to know if there are any infective features. So that may suggest vestibular neuritis, for example, although it doesn't necessarily mean that it's vestibular neuritis. You can have infective features with infective endocarditis or CNS vasculitis, both of which can cause strokes. It's good to know whether there are any oral features, so hearing features in addition to just hearing loss, so pain, tinnitus, fullness, or discharge. So that may suggest a peripheral problem, so Meniere's disease or vestibular neuritis with labyrinthine or cochlear involvement or ear infections. But of course, stroke can also cause oral symptoms, in particular hearing loss, especially if it's an ACA territory, so an anterior inferior cerebellar artery territory stroke. Headache is also a key symptom to know about. So headache may suggest migraine with vestibular features as a cause of sudden onset vestibular syndrome. However, stroke in the context of an intracerebral hemorrhage in particular, or an ischemic stroke in the context of a vertebral artery dissection, could also cause headache. So all of these features may help sway you in one direction or the other, but you just have to remember that none of them in isolation tells you for sure whether we're dealing with a central or a peripheral cause. So this is why the HiNTs examination is so helpful. It's highly sensitive and highly specific. However, it needs to be performed in the right patient, and it needs to be performed well, and it needs to be interpreted correctly. And there are quite a number of pitfalls or traps in the performing and the interpretation of the HiNTs exam, and it's a notoriously misunderstood examination. And so in this episode, I'm hoping to correct any of those misunderstandings so that you're all experts at the HiNTs examination by the end of the episode. One of the most confusing aspects is the way that the result is reported. So I would really ask you not to report the HiNTs exam as being positive or negative, because that's confusing. It's better to report the HiNTs examination as being HiNTs suggestive of a central cause for vertigo or HiNTs suggestive of a peripheral cause for vertigo. So let's dive into the 4 components of the HiNTs plus examination in turn. Let's begin at the beginning. So the head impulse test. What is this doing? So it's testing for usually unilateral dysfunction of the vestibulo-ocular reflex, the VOR, which is seen in peripheral causes of vertigo, especially vestibular neuritis. There are 2 different but closely related ways to establish a head impulse test. So the first thing you can do is you can start with the head in the middle, in the neutral position, and then rapidly turn the head 15 degrees to the left, like this. So you're doing it passively. Turn it quickly to the left, and then back to the middle, and then repeat to the right. And usually you do it a few times. That's how I've been taught to do it, and it's how I see most people in my country do the head impulse test. There is another way to do it though. You can start with the head 15 degrees to one side, let's say to the right, and then quickly turn it back to the neutral position. And then you can repeat by beginning with the head slightly off to the left, and then quickly move it back into the neutral position. There are some theoretical advantages advocated by some for this second method, such as being less likely to accidentally turn the head too far and less likely to evoke non-vestibular ocular reflex-related nystagmus on the head ending up in the neutral position as opposed to being in the lateral position. But personally, I find this method confusing because you're testing the left and right gets mixed up. And I think that the theoretical shortcomings of the first method are easily mitigated by just making sure you don't turn the head too far, and you shouldn't really be eliciting significant nystagmus, which is confused with a vestibular ocular reflex, especially just with a small turn to the head. So I prefer the first method, but ultimately either method is completely fine. So what tips would I have in regards to how to actually perform the head impulse test? Firstly, the eyes need to stay open. There's no point trying to do a head impulse test if the patient closes their eyes during it and you can't see where the eyes are moving. So you may need to passively keep the eyelids open. So when you're holding the head, you may need to use some of your digits, probably the thumbs, to actually passively lift the eyelids if the patient's so symptomatic that they just won't keep their eyes open. You may need to actually open the eyelids so you can see what the head is doing. And the same applies for the Dix-Hallpike maneuver. And one point that I was kicking myself about because I forgot to mention it in the cranial nerve examination video, so I'll mention it here instead, is when you're doing your H testing for your extraocular eye movement testing, when you're testing the third, fourth, and sixth nerve, the same concept applies. So there's no point testing extraocular eye movements if the eyes are half closed and you can't actually see the direction the eyes are moving in. And that's especially true when you're assessing down gaze. So you might not need to do this, but sometimes you do need to, again, passively elevate both upper eyelids with one hand whilst you're testing, especially the down gaze movements with the other hand, so that you can actually see what direction the eyes are moving in. So sorry for that little aside, but I wanted to get that in there somewhere. It can be difficult to do the head impulse test when the patient is quite stiff in the neck, so maybe they're symptomatic and vomiting and not having a good time, and they're not really in the mood for a doctor or another health professional to be moving their head around, or maybe they've got an extrapyramidal syndrome or musculoskeletal issues in their neck and spine, and they're arthritic and they just don't like you moving their head around. That can make it difficult. What I like to try and do is I support the head really clearly and firmly on both sides with both of my hands, and I just try and make the head a little bit floppy to begin with. So I say, look, I'm going to make your head floppy. I want you to be loosey-goosey, nice and relaxed. And then I say to the patient, look, I'm then going to do a small but quick movement, and I just want you to keep your eyes open and stay focusing on my nose. So nice and floppy, loosey-goosey, and then quick turn to one side, quick turn to the other side. One other point is practice, 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 and it's a lot easier to practice doing a head impulse test on someone who isn't vomiting and isn't possibly having an acute stroke. So you don't want to be trying to do this for the first time when you've got someone who's having a brainstem stroke in front of you. How do you actually interpret the findings? So it's worth talking about this a bit because it's a common source of confusion and it's good for anatomical revision as well. In a normal patient who, say, doesn't have vertigo and has a normal vestibular ocular reflex intact, what happens is that when you ask the patient to stay looking at your nose when you turn their head, when you turn the head, the patient's eyes will stay looking at your nose. So what that means is the head moves to the side, but the eyes actually move relative to the head so that it looks like the eyes actually don't move at all because they just stay looking at the spot. Of course, the eyes are moving because you've moved what they're sitting in, you've moved the head. So what's happened is the eyes have actually moved relative to the direction that the head is in so that they remain looking at the spot they were looking at initially, so it's as if the eyes haven't moved. Conversely, if you had, say, a brain dead patient who has no vestibular ocular reflex at all present, then what happens when you move the head is the eyes just move with the head. And that's what's called a doll's eyes response. So you could imagine if you had a doll with some buttons that have been stitched onto the head, and then you move the doll's head to the right, the eyes, of course, are going to move with the doll's head to the right, and the eyes will stay pointing in the same direction that the head is pointing in. So that's why it's called a doll's eyes response. Now, a patient who has peripheral vertigo, so for example, vestibular neuritis, they may have a partially impaired vestibular ocular reflex. So not completely impaired, not a complete doll's eyes, but it's not perfectly functioning either, so it's not a normal response. So what you get is when you move the head quickly to the side, the eyes initially move in the direction that the head is moving in, and then they realize, oops, we were meant to not do that. And so then you have this corrective saccade back to the examiner's eyes. So basically the eyes move with the head for a split second, there's this delay, and then there's this corrective saccade back into the middle. If you blink, you might miss it. So you have to look really, really, really closely for the corrective saccade. Now, the head impulse is said to be abnormal or positive to the direction that the head is turned in, as opposed to the direction of the corrective saccade. So if you're turning the patient's head to the right side and they have an initial delay before they have a corrective saccade back to the left, then the head impulse test is said to be positive or abnormal to the right, the direction that you move the head in. And that then localizes to the ipsilateral side of where the vestibular pathology is. So a positive head impulse test to the right, when moving the head to the right, is consistent with right-sided peripheral vestibular dysfunction, so a right-sided vestibular neuritis usually. So I hope that made sense. Now, in terms of vestibular neuritis, we'll get up to nystagmus next, but basically there's a discord between the direction of the nystagmus and the direction of the positive head impulse test. So in vestibular neuritis, the nystagmus should be contralateral to the side of the vestibular neuritis. So if you have a patient who has right-sided vestibular neuritis, they should have an abnormal head impulse test to the right, and they should have left beating nystagmus, especially on left lateral gaze. But we'll get up to the nystagmus shortly. Now, in BPPV, benign positional paroxysmal vertigo, the head impulse test is often normal. But importantly, BPPV isn't a cause of an acute persistent vertigo or an acute vestibular syndrome in the first place. So this isn't really what the HiNTs plus exam is designed for, and many people would argue that really you shouldn't be performing a HiNTs plus exam in a patient with clear-cut BPPV to begin with. Now, in a patient with central vertigo, particularly a stroke, the problem is usually not in the VOR pathway itself, the vestibular ocular reflex pathway itself. Therefore, the vestibular ocular reflex should usually be intact, just as it is in a normal asymptomatic patient. However, as you may have guessed, and because I was stressing usually so much, this is not perfect, because you can get some strokes or some other central lesions affecting the central nervous system, which actually can affect the vestibular ocular reflex pathway. So I've just pulled this image off the internet. It's licensed through a Creative Commons license through the Wikimedia group, so I believe that legally I'm allowed to show it here. And I've just shown it here. I'm not going to go through all the details of all the different anatomic landmarks in the pathway, but it's just a way of demonstrating that the components involved in the vestibular ocular reflex include the oculomotor nucleus in the midbrain, the abducens nucleus in the pons, and the vestibular nucleus of the eighth nerve in both the pons and the medulla. Therefore, if you have a brainstem lesion, including a stroke, which is affecting the midbrain or the pons, so affecting the third nerve nucleus in the midbrain, the sixth nerve nucleus in the pons, or the eighth nerve nucleus, the vestibular nucleus in the pons and the medulla, then this pathway could be impaired. So a central cause of vertigo can sometimes, not usually, but sometimes cause an abnormal head impulse test. However, in that context, you would usually expect there to be additional brainstem signs also present. And in particular, that would include skew deviation. And as we're about to see, that's one of the other components of the assessment. So that's why the assessment has to be done and considered as a whole. And we're going to get to the interpretation of the findings shortly. We've just spoken about the head impulse test. Let's move on to the next parts. So next is nystagmus. Nystagmus, if it's present, can either be vertical, horizontal, diagonal, torsional, and it can be unidirectional or it can be multidirectional or direction changing. Which ones are consistent with central and which ones are consistent with peripheral causes of vertigo? So, central vertigo is likely, if it causes vertigo, to be causing the bad types of nystagmus, basically. So, vertical, diagonal, torsional, or direction changing. To say it again, vertical, diagonal, torsional, or direction changing. So that is bad. That is consistent or suggestive of central vertigo. And we're talking about nystagmus with the eye at rest or the eye with basic eye movement testing. Of course, as many of you may know, when doing a Dix-Hallpike examination for BPPV, you classically get nystagmus with a torsional component, but we're not talking about torsional nystagmus when you're doing a Dix-Hallpike examination. We're just talking about nystagmus at rest or when the patient is looking from side to side. Conversely, if you have nystagmus which is both horizontal and unidirectional, so left beating horizontal nystagmus, which is always left beating, or right beating horizontal nystagmus, which is always right beating, and the direction of the beating is defined by the fast phase of the nystagmus, then that is a green flag in a way. So that's less concerning and it's suggestive of a peripheral cause of vertigo as opposed to a central cause of vertigo. And usually the nystagmus will be more pronounced when looking in the direction that the nystagmus is beating in. So if you've got someone with right beating horizontal nystagmus, it may only be present when they're looking to the right, and then it may be less present when they're looking in the middle, or it might be absent when they're looking in the middle, and it may be less present still or completely absent when they're looking to the left side. One important note here is that a lot of people don't recognize that a few beats, so 1 or 2 beats of subtle, non-sustained horizontal nystagmus in the direction of gaze, which is elicited at the extreme of horizontal gaze, is a normal, insignificant finding, and that does not constitute true direction-changing nystagmus. So if you, the next time you're in a room with another person, you could just do some finger extraocular movement testing and get them to look at the absolute extreme of right lateral gaze and get them to look at the absolute extreme of left lateral gaze, and not an insignificant proportion of normal people might just have 1 or 2 little subtle beats of right beating nystagmus at the extreme of right lateral gaze, or 1 or 2 little beats of nystagmus to the left at the extreme of left lateral gaze. That is not a red flag. That is not a concern. That's normal. So please don't overinterpret that. What we're talking about in terms of direction changing nystagmus is more significant nystagmus, so more prolonged, more sustained nystagmus, and nystagmus which is elicited not just at the absolute extreme of gaze when it's painful to keep looking that far, but less extreme directions of gaze. So I hope that's made sense. Next, let's move on to test of skew. So skew is referring to if you're looking at the eye positions and then you cover up one eye suddenly, does the other eye move? And if it does move, that movement can be skewed in the horizontal plane or in the vertical plane. And it's important to realize that horizontal skew is a completely normal phenomenon. And that's because we have binocular vision and our eyes are positioned in the same horizontal plane, but at different points in that plane. So if you, with your binocular vision, with your 2 eyes, focus on one point off in the distance and then you cover one eye, then it's actually normal for the other eye to adjust slightly horizontally to continue focusing on whatever you were focusing on before. So again, you could test that if you're with another person now or in the future, next time you see another person, you could test that, ask them to look off into the distance and then cover one eye. And it might be such a small change that it's not actually perceptible to you, so you don't see it in everyone, but it's a common thing that you do see, and it's a normal finding for the eye to correct a bit in the horizontal plane. Conversely, it is not normal for the eye to correct in the vertical plane. And that's because, of course, one eye isn't on top of each other. So our eyes are next to each other. They're not on top of each other. So when we're focusing on a point in the distance, if you cover one eye, the other eye shouldn't have to correct in terms of looking up or down because it should already be looking at the right level in terms of the vertical plane. But if there's a patient who has brainstem involvement affecting some of the pathways that I discussed previously, then it's common that they will get some vertical skew deviation. And that is bad, and that is consistent with a central cause or suggestive of a central cause of vertigo. So in order to actually test it, what you're doing is you're covering and uncovering one eye a few times whilst the patient's looking at something in the distance and looking for any vertical skew deviation. And then you're doing it in the other eye, and that's how I like to do it. I have seen some people swap eye to eye, so they'll cover the left and then the right and then the left and then the right as if they're doing a swinging light test, but by covering the eye instead of putting light in the eye. That's okay as well. That's completely fine. I don't love doing that. It just confuses me a bit. I prefer just to cover one eye a few times, cover, uncover, cover, uncover, cover, uncover, and then go across to the other eye, because that also gets the job done, and I just find it a bit less confusing, but it's up to you as to which of the two you'd like to pursue. Now, the last component of the HiNTs plus examination is the plus. So that refers to associated new onset hearing loss. So not any oral symptom, hearing loss. And this is a potential red flag for an AICA, an ACA stroke, as I mentioned at the beginning of the episode. Of course, hearing loss can be seen in a number of peripheral causes of vertigo as well, as we mentioned earlier. So vestibular neuritis, which is also involving the labyrinthine or the cochlear systems, an ear infection, otitis media, for example, Meniere's disease, they can all cause hearing loss as well. So it doesn't mean that it's definitely a stroke, but it is a potential red flag for a stroke. So you get a big red cross if you've got new onset hearing loss. And in terms of examining for hearing loss, that's just the same as how I described it in the cranial nerve examination. So we're just doing a basic bedside assessment of hearing. And I would recommend just by doing a little brief rub of your fingers in one ear, seeing if they can hear it, doing a basic little brief rub of your fingers in the other ear and seeing if they can hear it. And if they can, that's good. If they can't, then that's not good. And we're not so interested in oral neglect at this point. We're just seeing, can the patient hear or not? So, putting the HiNTs together, as promised, let's talk about how you interpret the HiNTs examination. So, this is where everyone gets tripped up. If you have an abnormal head impulse test, a normal nystagmus testing, so that means either no nystagmus or you just have unidirectional horizontal nystagmus, not anything else. And if you have normal vertical skew testing, and if you have no acute hearing loss, then that counts as HiNTs being suggestive of a peripheral cause. And it's much clearer to speak in those terms rather than saying HiNTs negative. Conversely, if you have a normal head impulse test or abnormal nystagmus or abnormal vertical skew or acute hearing loss, then that's consistent with HiNTs suggestive of a central cause, which is less confusing than saying HiNTs positive. And of course, the confusing bit is the double negative, which is hidden away here in regards to the head impulse test, and that's where everyone gets confused. So remember that the abnormal head impulse test is what you get in HiNTs being suggestive of peripheral, whereas a normal head impulse test is what you get in the HiNTs consistent with central. One thing to note here, however, is that if you're examining someone after the symptoms have already completely resolved, then you would expect the head impulse test to be normal. And that doesn't mean that they had a central cause for their vertigo. So if you had someone who had, say, vestibular neuritis, and then you're examining them after they're already better, then you wouldn't expect them to have an abnormal head impulse test. But that doesn't mean that it was a stroke, not vestibular neuritis. It just means that you're not examining them at the right time. You weren't in the heat of the moment. But again, this is why it's important that you're interpreting the HiNTs in the context of the patient in front of you and applying it to the right patient. So it really is for use in the context of a patient who has an acute vestibular syndrome, so a sudden onset or reasonably sudden onset, persistent, non-episodic, non-triggered vertigo, and you're trying to tease out, is this patient's vertigo in front of me likely or suggestive to be from a central cause, or is it from a peripheral cause? Now, putting the HiNTs together, how good is it? It's not perfect, but it's pretty darn good. So it has a sensitivity of 96 to 100% and a specificity of 96 to 98% based on a paper that I read about the HiNTs exam. So that's pretty good, but that's assuming that the HiNTs exam is performed properly. So hopefully now you're all absolute experts at the HiNTs exam. Now, let's just take a moment to compare vestibular neuritis and stroke because we've been talking about that a lot. So, vestibular neuritis can present very acutely and very severely, and it really can mimic a posterior circulation stroke. It's important to note that in a patient without any other red flag features on the history or on the examination of stroke, and with a HiNTs that's suggestive of a peripheral etiology, then it's very likely that it's vestibular neuritis rather than stroke, particularly in the absence of any vascular risk factors. And it would be really quite unusual, not unheard of, but unusual for stroke to manifest with isolated vertigo with nothing at all else. If you think about the anatomy, for a stroke to just pick off a component of the vestibular system and cause vertigo, but not pick off anything else in the adjacent central structures in the brainstem to cause any other neurologic deficits, that'd be pretty unlikely. So if someone has, say, a niece of 0 and they just have vertigo and there's nothing else, it's unlikely that this is going to be a stroke. And if you think about it, even if it was a stroke, their niece is going to be very low, probably a 0. And so they're not going to be a candidate for thrombolysis or mechanical thrombectomy anyway, if we're going by the books and applying the literature. That being said, you should always, if you're not the neurologist on call, if you're a junior doctor, then I would recommend always discussing this with the neurologist on call, because there is some variation in people's practice. So some neurologists would have a bit of a more cautious approach, and they may choose to perform a CT and a CT angiogram plus or minus a CT perfusion in some cases if there is any diagnostic uncertainty, especially if the patient has lots of risk factors, if the patient's a vascular path or they've had strokes in the past, because of the dire consequences of misdiagnosis. And also, it can be difficult if you're not the person in front of the patient and you're making the management call on the other end of the phone. Sometimes it can be hard to, have complete faith and complete trust in the person that's calling you, especially when it's quite tricky neurologic examinations, which are notoriously performed incorrectly sometimes or misinterpreted. So I have heard lots of stories of colleagues not doing a CT because they thought it was peripheral based on information they had been told, and then unfortunately they then see the patient the next day and it was a fairly obvious, subtle but not so subtle stroke that had been missed. And there's lots of complicated ethico-legal aspects to this. So I would recommend at a pragmatic level, if you have a patient with vestibular neuritis and if there's any doubt whatsoever, or even if there's not really any doubt, I'd still discuss it with the neurologist before you make the decision not to image the patient. Now, we're going to completely change tact and we're going to go on to other examinations which are relevant in the vestibular pathway. But we're not talking about acute vestibular syndromes now. We're not trying to distinguish stroke from vestibular neuritis. Now we're talking about examinations and maneuvers for BPPV, benign paroxysmal positional vertigo. So even though this is an episode about examination, really the history should be what gives the diagnosis away. So the vertigo in BPPV should last for seconds, up to a few minutes at most. It should be provoked by head movements, and there should be an absence of other symptoms and signs which are suggestive of an alternative peripheral or central diagnosis. So it's a cause of a triggered episodic vertigo. So triggered is triggered by head movements, and episodic is clearly paroxysmal. And it's good to recognize that BPPV can also be post-traumatic. So if someone has a fall or a head strike for some other reason, that can then dislodge the otoliths into the semicircular canals, and that can actually be an etiological cause for BPPV. And sometimes that can be more difficult to manage because it may be multi-canal or bilateral and such. What maneuvers do you do? The one that you're most likely to have heard of before is the Dix-Hallpike maneuver. And that's the one that we always start with. So that is the test that you do to diagnose posterior canal BPPV, which is the most common form of BPPV. And the abnormal response should be ipsilateral to the side of the lesion. So if the head is turned to the right with the neck extended in the BPPV, and that causes torsional right beating nystagmus, then that's consistent with right posterior canal BPPV. So how do you actually do a Dix-Hallpike maneuver? Let's talk through the steps. So in terms of positioning, there's two ways you can do it. You can do it with the patient in the bed longitudinally, so lying in the orientation that the bed is in, but sitting upright with the bed flat behind them, and positioning a pillow deliberately underneath the small of their back, and then with the intention of then leaning the patient backwards like this. This is the way that I very much prefer to do my Dix-Hallpike examinations, and I'll explain why shortly. The other way that you can do it, which lots of people do, is instead to have the patient sitting over the side of the bed and obviously making sure the bed isn't pushed up against a wall so that there's no wall in the way on the other side of the bed. Then what you do, in either method, what you do is you laterally rotate the head to one side passively. So if you're doing it to the left, for example, and if you're watching on video, you passively laterally rotate the head to the left. And typically, well, what you should do, I should say, is slightly extend the neck as well. And then immediately after you've done that, you keep the head in that position and you quickly, passively cause truncal extension so that the patient falls backwards in a supported manner so that they're flat, and then you've already placed the pillow beneath the small of their back so that they actually go a little bit below flat, so they're actually dangling upside down just a little bit. And then what you need to do is you need to look at the eyes. And as I mentioned earlier, the eyes need to be open. There's no point doing a Dix-Hallpike and then the patient closing their eyes because they're symptomatic and then you can't see the eye movements. So you may need to passively keep the eyes open. And you have to be quick with this movement. So you can't be slow, you have to be quick. And the lateral head movement should be a decent lateral head movement. We're not talking about a wussy little turn to the head, a wussy 15-degree turn to the side. It should be a proper head turn to the side with extension and then a quick fall back so that the head is laterally rotated, slightly extended, and dangling slightly below level when they're dangling a bit upside down. And then you have to look for the nystagmus. Typically, there's a very brief delay prior to the onset of the nystagmus, so you might see no nystagmus initially, and then after a second or two, you then see the nystagmus. That's not always the case, but that's typically what you see. And you should look for, people sometimes say up to 30 seconds. I think that's probably overdoing it a bit. I can't say that I've ever seen a delay anywhere near that long before. So I'll leave that up to you as to how long you want to watch for. I would usually watch for about 15 seconds, I would say. And then you sit the patient up and you repeat the process to the other side. Simple. The type of nystagmus, which I mentioned before, should be torsional or rotational nystagmus. And it's usually torsional, but largely a horizontal, but with a torsional component. I said before that I prefer my method and I have a reason for it, and this is the reason. What are you actually going to do when you diagnose someone with posterior canal BPPV? Well, you want to fix it. And the way that you can fix it non-pharmacologically, which is what we always like in medicine and in neurology, if there's a non-pharmacological fix for something, then you should go with that. And we've got one for posterior canal BPPV, and it's the Epley manoeuvre, which you may have heard of. So there's various vestibular exercises that can be used, including the Epley manoeuvre. And it's very easy to perform. And honestly, I think it's a bit lazy not to do one. If you've diagnosed someone with posterior canal BPPV on the basis of a positive Dix-Hallpike, why wouldn't you do an Epley? That just seems cruel to me to not do one. You've got the patient right there in front of you. You may as well try and fix their problem. So you really should do an Epley manoeuvre. And the Epley manoeuvre, conveniently, is just a continuation of the first step of the Dix-Hallpike. But it's really hard to do the Epley manoeuvre if you initially position the patient with their legs dangling over the edge of the bed because you run out of bed space and you run out of room. But that's not a problem if you do it with the patient lying in the angle that the bed is oriented in and just sitting up with the pillow behind the small of their back. How do you actually do it? So let's suppose that the patient has a positive Dix-Hallpike to the right. So you've already done the Dix-Hallpike to the right, so you've already lowered the patient down with the neck turned laterally to the right. You've seen the rotational nystagmus, you've diagnosed the right posterior canal BPPV. So that's already the first step of an Epley manoeuvre, essentially. Then you just do the next step. So you wait 30 seconds, and then with the patient still lying down like they are, you then quickly turn their head across to the left side, and then you wait another 30 seconds. And then you roll the patient's whole body onto the left side so that they're then in the left lateral position, and you wait another 30 seconds. And then you sit the patient up, but the way that you sit them up is you get them to stay initially in the left lateral position, and then you help support them by lifting their lower shoulder up so that they're then sitting up with their legs dangling off the side of the bed. And then that's done, and that's it. In addition to that, symptomatic treatment with antiemetics is often necessary. It's important that you don't accidentally perform a Dix-Hallpike in the wrong way around. So if you accidentally turn the patient in the wrong direction, for the side of the BPPV that the patient actually has, because that can actually make the BPPV worse, and you can get the otoliths even more dislodged, or you can convert one form of BPPV into another, and you don't want to do that. So the way to remember which way to perform the Epley manoeuvre, which direction to turn the patient in, just remember that it's a continuation of the abnormal side that the Dix-Hallpike is performed in. So if the Dix-Hallpike is abnormal to the right, you've already done the first step of the Epley, so then the next step is to then rotate the head across to the left side. So what if the patient doesn't have posterior canal BPPV? What about the other canals? Well, the next most common one is the horizontal canal. And this is diagnosed with a head roll test or a log roll test. And in practice, this can easily be performed immediately after you've done your Dix-Hallpike examination. So suppose you've done your Dix-Hallpike to the left, then you've done your Dix-Hallpike to the right, and you still don't know what's going on. So you think, oh, maybe this could be horizontal canal BPPV, let's do a log roll. So what you do is you've already got the patient lying down, so you've got the patient lying supine with the head in a neutral position or a near neutral position. And then you just turn the head to one side and you observe for nystagmus. And then you repeat the procedure to the other side. So the patient's already lying down, and then you roll their head to one side, test for nystagmus, back into the middle, and then turn the head to the other side, test for nystagmus, back into the middle. And the thing that you get in horizontal canal BPPV in terms of the semiology of the nystagmus is different. But it's actually quite neat when you think about it. So there's two different forms of horizontal canal BPPV. There's geotropic and ageotropic. So geotropic horizontal canal BPPV, as the name implies, geo, as in the earth, the ground, the nystagmus points towards the ground. So that means when you do the head roll test to the right, they will have nystagmus beating to the right towards the ground. And then when you do the maneuver to the left, the patient this time will have nystagmus going to the left, again towards the ground. And then, well, which ear is involved? Well, it's the side with the more profound nystagmus, and that lateralizes ipsilateral to the side of the lesion. So if you do your head roll test and they have strong geotropic nystagmus on the right side and weak geotropic nystagmus on the left side, then that is consistent with right horizontal canal geotropic BPPV. Ageotropic is the exact same, but the complete opposite. So instead of beating towards the ground, it beats towards the ceiling instead. Now, how do you actually treat horizontal canal BPPV? Well, it's with another maneuver, but it's not the Epley maneuver, it's a different maneuver called the barbeque roll or the Lampert roll maneuver. That's the eponymous name. So it's basically stepwise rotations of the non-tilted head, and you start in the supine position and move through 90 degrees in incremental steps. And again, you don't want to roll them in the wrong direction. And the way to remember it is that you start in the affected ear with the patient pointing towards the affected ear, then you roll them supine, then you roll them to the unaffected ear side, then you roll them prone, then you roll them back to the affected ear, and then you sit them up. And again, you're doing about 30 seconds for each step. So, for an example, if you have a patient with right horizontal canal BPPV, especially if it's geotropic, then you're going to have them lying supine, and they're going to be, sorry, they're not really supine, they're flat. They were supine, but they're flat now, and they're starting on the side where the affected ear is. So they're rolled onto the right lateral position. Then you roll them supine, then you roll them into the left lateral position, then you roll them prone, then you roll them back into the right lateral position. So they've done a full 360, and then you sit them up with 30 seconds for each step. This works best for geotropic horizontal canal BPPV. It might also work for ageotropic horizontal canal BPPV, but it might not, in which case it may require advanced and more aggressive manoeuvres. And I would personally recommend referring the patient to a vestibular physiotherapist or a vestibular neurologist subspecialist at that point. And similarly, if the patient has either anterior canal BPPV or they have multiple canal BPPV or they have bilateral BPPV, then these are obviously much more complex presentations of BPPV, and I would definitely be referring the patient to a vestibular neurologist subspecialist or a vestibular physiotherapist at that point. And that's it for today. Thank you so much for tuning in. If you found this episode valuable, then please do like, comment, and subscribe because it really does help out the project a lot. Please visit our website at rneurologyeducation.org. That's R for the letter R, for all of our media formats and additional content. Find our videos on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all located at the domain at rneurologyeducation, and that's R for the letter R. And email us on contact@rneurologyeducation.org with any questions that you may have, or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.